What I recommend that patients ask their surgeons before anything is done is, first of all, what is their level of experience with a given procedure? For example, there are a number of neurosurgeons, many neurosurgeons in this country who are primarily spine neurosurgeons. They don't do intracranial work, but they are board certified to do intracranial procedures, and they can do this. And in most circumstances, or certainly in certain circumstances, that's acceptable. To do a biopsy, for example, or to do a resection of a very straightforward tumor. But for the most part, with brain tumors, it's better to work with a specialist, someone who spends most of their time doing that. That doesn't mean 1 or 2 cases a month or 1 or 2 cases every month, every other month. What it really means is at least several cases a week, that somebody is primarily devoting at least 75+% of their practice to doing neurosurgical oncology. So I think experience is important. And then to further define that, for example, if it is a tumor in the dominant hemisphere, which means a tumor on the left side of the brain, for example, in a right-handed person, where both the physician and the patient should be concerned about the risk of language impairment, then I think it's very important for the patient to ask that physician what their experience is in operating on tumors in that part of the brain. So experience is critical, even for those tumor surgeons who specialize in the field. The second thing, I think, has to do with the complication profile of the procedure. You have to be, as a patient, comfortable in hearing from a physician what the expected complications are for a given procedure. And that ranges from straightforward things like postoperative infections to postoperative hemorrhages to the specific nuances of a given type of a deficit, like impairment of speech or inability to move or numbness, sensory dysfunction, blindness, things like that. So it's very important to try to get a sense for what the risk is and to try and hear the likelihood of the risk. Is it likely in terms of 10%, 50%? Something like that. It has to be quantified to some degree. It can never be exact, but to some degree. And then I think the final point is to understand the issues that are going to happen during the hospitalization and afterwards. So in other words, what are the post-operative issues that are going to come forward? What's the likelihood of seizures? What's the likelihood of having fevers or potential for infection? And how do we recognize those things? What happens if I'm discharged home and all of a sudden I get a fever and my wound looks a little red? What do I do? What do I do if a seizure occurs? How do we handle that? Do we call 911 or do we come right back in to the emergency room? And we need to know who is going to be the primary person responsible for that individual 24/7, especially during the first few weeks. So the postoperative course is important. For example, if you tell a patient that they're going to have weakness for at least a week, you have to make sure that somebody's going to be available for that individual to care for them 24/7. So I think these are the 3 big things that need to be defined.